This morning we talked about, different treatments and, certainly, for patients who are newly diagnosed, we often talk about outcomes such as, tumor control, progression-free survival, and survival, but outcomes that matter just as much are really quality of life outcomes, and I think we're doing a better job in terms of engaging our colleagues from pain management and certainly physical medicine rehabilitation. The goal of this session really is to talk about, once you've had your initial treatment, how do you deal with that recovery? And then we also have a speaker for managed care, Mr. Fred Castellano, talking about navigating the health insurance landscape. As Josh mentioned earlier, even with recurrence, this is something that's a process that you deal with over quite a long period of time. And given all the changes in health insurance that we're currently dealing with, and that's sort of the nature of being in the United States, it can be complicated for even a clinician to navigate. And so that was the reason why we included that in this session, because I think there's things that you should keep in mind with all the changes. So we're going to start out first with Dr. Carlos Roldan. He's one of our pain management gurus, and so he's going to talk about some of the pain management issues related to what you all face.
The mouse. Okay, got it. Hello, everyone. Thank you for this invitation. It's truly a privilege to be here and a true honor to work for the MD Anderson community. So, just gonna give you a little bit of my background. I practiced emergency medicine for more than 10 years. And my focus was always the quality of life. So I understood the quality of life was priority. And treating pain was giving me this opportunity to get back to my patients. So that was my focus. Unfortunately, in emergency medicine, that's not the best environment. It's not the most conducive environment to do so. So eventually, I pursued my training in pain medicine. And then after my training in pain medicine, I was offered to stay in MD Anderson. That's what I'm doing right now. And I truly think that this is what I'm going to do for the rest of my career. So you're going to see me, if you are MD Anderson patients, a good chance we're going to see each other again. I start first with the definition of pain. I only have a few minutes, so I'm going to go over a few things. So in 1979, the International Association for the Study of Pain adopted this definition of pain. Still, as of today, we still take the same definition. Pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. So the importance of this definition is when you look at there's two components, sensory and emotional. So pain is not this single symptom associated with tissue damage. It's a lot more complex than that. So we can never anticipate that pain is just blocking the symptom, just putting a needle and blocking the nerve or doing a pill that's going to control the pain, and that's the only thing. Actually, when you're talking about pain, especially pain and cancer, it looks more like peeling an onion. It's multiple layers, and it's a lot of tears in between. So we start with the tissue damage, and there's also pain sensation, thoughts, emotions, suffering, pain behavior, and much more from that. So once we talk about this one, and pain becomes the center of your life, even beyond survival or, when you're dealing with cancer. So the quality of life can be impaired in many ways. There's many spheres of the quality of life that are associated to pain. When you have pain, you probably have difficulty to sleep. You also have mood changes. If you cannot sleep, your energy is down. Your activity level is lower. So all of those interact to each other. So they all feel each other with pain in the middle. So that makes more complex the job that we do. We're not just doing a pill to block the symptom. So one of these recent publications that I saw, where they address it's more a self-reported quality of life, some questionnaires are multiple published, and I just look at this one, it's a little bit larger than most of the others. They included 358 patients and 202 caregivers. Some of the important numbers is patients' complaints. Of course, the most common was pain, 35% of the patients, anxiety, 32%, fatigue, 31%. But there was also multiple concerns besides the physical symptoms. Delayed care, 37%, disability, 33%, and unresolved questions by providers. But more interesting is when you start pretty much validating what I've just said. This is not something that stays with the patient itself. It goes even beyond. Among the caregivers, there were also some questions that were answered, and probably the most remarkable was the grief. 55% of the caregivers were also suffering because their relatives' problem. Delayed diagnosis, 47%, and difficulty helping patient coping with disease was also a big deal, 45%. So when we see this, we're talking not just about the patient with cancer and pain, we're talking probably about the family in pain. And this is something that's been discussed at multiple levels in psychology and in pain, of course, when not only the patient, but also other members of the family are involved in the same circle. So there's a lot of guilt, fear, anger, loss, and sadness that can compromise patient, families, and other relatives. So many times when we're trying to address the pain in the patient with cancer, we understand that this is something that is also involving other patients, other parts of the family. And therefore, the approach is going to be sometimes not only focused on the patient, but we need to do more than that. As you might expect in a supportive environment, probably the patient have a better outcome than where it's the opposite. So overall, cancer pain is very common. About 70% of the people undergoing cancer treatment experience pain. The prevalence can be from low to high, and of course, in advanced stages, is expected to be pretty high. So people with advanced stages of cancer, up to 90% of them present pain. And the most common cause of the pain in these patients are directly related to the tumor infiltration. But more interesting than that is that treatment of cancer can cause pain as well. So it's not just cancer itself, it's the treatment. We can actually produce a lot of pain, and we see that in our practice all the time. I would say probably that the best way to understand the complexity of the problem is going through the mechanisms of pain. Unfortunately, many people that enter the world of chordoma, they already come with chronic pain from other sources. So not everybody just comes with chordoma with no experience of pain. Some of them, they have multiple encounters with chronic pain. And by statistics, the premorbid pain by location most commonly is low back, 27%, headache, 15%, neck pain, 15%, facial pain, 4%. By cause, cancer is number one. Interestingly and unfortunately, many patients that are diagnosed with chordoma have already survived another cancer. And we see, unfortunately, many times where the second or third cancer patients have survived multiple cancers, they already have with chronic pain, and now they're having another cancer diagnosed. I don't have any statistics to see how often this happens in the chordoma patient. Other sources of chronic pain include osteoarthritis and rheumatoid arthritis, surgeries, and spinal pathology. The tumor itself, when you have a mass occupying space, there's going to be distortion, compression, erosion, damage and involving. It's going to be all the mechanisms included in the location of the tumor that is going to be directly causes of pain. That's including bone, soft tissue, nerves, ligament, and fascia. They all to be treated differently. There are different mechanisms. They are to be managed in a different way. It could be very complex, and more so, and we're talking about chordoma, when there's a regional relapse. So person already has pain from the tumor, and then a relapse, and we're going through a second surgery, and that's probably, we're anticipating there's going to be more pain or changes on the baseline pain. Metastasis, well, the metastasis also will be treated to like an additional pain, but in a different location. It's all go by size and location, and the symptoms will be definitely correlated with that. Body mechanism. This is a very interesting thing that we see in our practice, where we see that the pain is not only necessarily coming from cancer. So the tumor is in one location, but you start having pain in another location. Not necessarily means that the cancer is there, and this is a question that we face frequently. Once the tumor, the cancer is in the axial skeleton, there's going to be a concept that's going to enter into this body, which is a skeletal asymmetry. And there's going to be functional and anatomic asymmetry. The mechanism is from multiple sources, avoiding positions. You have uncomfort one side of your body, one side of your body. Even unconsciously, you start adopting certain positions, sleeping in certain ways, sitting in certain way. With those, you're gonna be doing some compensatory changes where there's abnormal posturing, the ergonomics changes, if the tumor's in the sacrum, so how you're gonna sit, how you're gonna drive, many things is gonna change. Overuse and underuse, so based on the same mechanism, because the body is not the same and you have to accommodate to that, many other things are start hurting. All of those areas that were not used now are overused or they're underused. So that's part of the pathology that we see, and of course, antalgic gait is part of that. So even that we're focusing to the tumor and the surgery, and we're focusing to that area, is very common that we see what we'll call the satellite effects of the cancer. From the posturing that I mentioned, from the alteration of the skeletal, compensatory things that we do, you can start developing some tendonitis or other areas of overuse that become part of the problem we have, even with they're not directly related to cancer. Treatment related, I already mentioned, when the patient is going under treatment for cancer, we're expecting some of the treatments actually could be potentially generators of pain. As the most common source of the treatment in the chordoma patient is surgery, we are aware of the en bloc resection where the body is not going to be the same. So, we're going to be dealing with post-surgical pain, and if unfortunately there's a recurrence and a repeat surgery, there's going to be additional pain, probably expanding the same location of the removal. There's always surgical complications, healing, anatomic disruption, function loss, adaptation, poor adaptation to the new self, and very important, the sacral tumor removal. Many times there's going to be also nerve roots or nerve removals, and depending on the level of the nerve compromise, we also anticipate the type of dysfunction that's going to be subsequent to the treatment. We're talking about lower limb dysfunction, bowel, bladder, or even sexual dysfunction. They're all going to be part and components of the complexity of pain and the quality of life. Now, related to radiation therapy, even with new technology, more precise technology, we know that there is a direct correlation between the length of the treatment, the more radiation, and the intensity of the radiation. There's always going to be a higher chance of developing pain secondary to the radiation therapy. Something that we need to know is that there's something that is called the bystander effect, where cells or tissue that are in the vicinity of the radiated tissue, not necessarily affected by radiation, they can also be subject to damage. And that goes depending on the location of the radiation. So some of the effects of the radiation therapy will be early, so they can be seen within days or weeks from the radiation. And that goes from, the local irritation or burn of the skin where the beam is being applied, hair loss, skin mucositis, diarrhea, but others that are not necessarily evident immediately, it can take months to years to develop. When we're talking about radiation, probably the landmark of this is fibrosis. Fibrosis is tissue that becomes less elastic, weaker, poor healing, and of course associated to neuropathy and pain. We're also looking at atrophy, vascular damage, nerve damage, lymphedema, and it goes specifically to every organ. I put here a list of them, probably from the most sensitive to the less sensitive organs exposed to radiation. So depending on the area that is being exposed to radiation, you probably start anticipating what other symptoms and what other pain the patient might present in the days or months to come. Systemic therapy, even that is not probably the common pathway in the treatment of the patient with chordoma. Some of the patients undergo systemic therapy, and when we talk about chemotherapy, probably the landmark of chemotherapy is peripheral neuropathy. It's something that we see every single day. Steroids, if they are used, it's going to be not only an issue when they use the steroids, but also with the withdrawal of the steroids. Something that we see, and it's very common, the joint pain secondary to the pseudo-rheumatism, secondary to the steroids withdrawal. Hormonal therapy, it can be a source of bone pain, and it's typically also one particular trigger or perpetrator of the migraine Patients with prior migraines or patients with no migraines after hormone therapy might start presenting migraines as well. And if you see, we're still talking about other extended effects, not necessarily directly to cancer itself. Growth factors, also in acute pain, bone, muscles, and joints, and immunotherapy can have similar type of side effects. So having said this, with the complexity of the pain, so the expectations need to be discussed directly with the patient. We never anticipate or promise that the patient will be pain-free. It takes a little bit more than that. So the treatment, if we can accomplish pain-free, that would be great. But every single case needs to be individualized because every patient has different profile and different restrictions and different conditions for the pain. So it has to be individualized, and it should never be expected that it's going to be one single way to treat the pain. And we're talking specifically about narcotics. It's not uncommon for us to see patients that they're suffering, they're having a lot of pain, and probably the anticipation is that the treatment will be given a stronger narcotic or something that a bigger dose or stronger narcotic, which is not necessarily the right answer. So the treatment is going to be approached depending on each individual case, and of course, it's going to take a village to help. So as the pain consultant, we probably do a lot of the treatments multimodal, which means multiple type of pharmacological approaches with depending on what pain we're talking about, inflammatory, neuropathic, nociceptive, visceral, it's all completely different. We also do a lot of procedures that are intended to help with the pain, but there's no question that we need other specialties in order to get this accomplished. So we have interventional treatment, but also we have psychological support, physical rehabilitation, complementary and alternative treatments, etc. So it takes a lot of effort. So to finish this short presentation, I want to bring this quote that is used frequently in psychology and in the pain field. This is from a Japanese writer, Haruki Murakami. Pain is inevitable, suffering is optional. So pain is going to be present. There is a tumor, there's tissue damage, there's always going to be a physiological transmission of a sensory to the brain. What is going to make a change is the interpretation of the patient. So with good skills of acceptance, coping, and mindfulness, the patient will be able to balance the cognitive and emotional component of the pain. Basically with that, the anger, frustration, sadness, helplessness, and other affective components of the pain can be actually controlled. And probably with that, we'll be able to have a better outcome in our patients. I'll be happy to answer any questions if there is. Thank you.